Well, welcome everybody. We're delighted to have you here again this morning on Thursday for our fellowship lecture series. I just a couple of announcements that I wanted to forward to the group. One, it's with sadness that we report, and you should have gotten an email about this, the death of one of our friends and colleagues, Dr. David Sharp. Those who've been part of our program for a long time knew David well. David was lecturing in this fellowship program since virtually the beginning, and those of us that have been around a while remember his lectures on history. He was a historian and did a wonderful job in terms of helping us understand the history of our specialty. And he did some on imminently dying, and he did lectures on prognostication. And he was just a wonderful mentor to a lot of folks. And I think fortunate for many of us, he sort of didn't know how to retire, and he continued to find his way back into the hospice field to do a few more things. And so he was just a wonderful man, wonderful doctor, and a great friend, and a real supporter of us and our program. And David was diagnosed with lung cancer earlier in the year, and died peacefully at home with Babs by his side. And so we're grateful for David and his legacy, and I just wanted to acknowledge him in this forum. I also wanted to highlight for those that may not be in certain channels of communication, our own Dr. Dupuy received an award from Fox 17. They have a Spotlight Award for healthcare professionals, and he is the award winner. And so we're just, again, for those of you that have hung around Steve know his passion for the field. What just a wonderful presence he is, and great supporter of this fellowship program and our efforts here. So congratulations, Steve, and we're just grateful to have you as part of our team. I would like to introduce Barbara Opperwall. I've known Barb for many years. She has worked closely in the hospice and palliative field for a long time. She'll tell more about what she does and what she has done, and has been a faithful supporter of the program here, with lectures that have turned out to be really quite popular, and in fact helped her garner our first Teacher of the Year award for our fellowship program when we started doing that a few years back. And Barb has retired, but we are very grateful that she continues to come back and bless us with her presentations. And so, Barb, we're just delighted to have you here again. I know that the fellows will learn and grow, and I learn something every time you talk, so I'm just excited for me. So anyway, take it away, Barb.
Thank you, John. You were too kind. And good morning to friends, fellows, former colleagues. I'm delighted to be here. This is a favorite topic of mine, and I know that for many, family conferences, family meetings are just no big deal, and they are very comfortable with that process. For some, they strike fear in the heart. And we're going to learn a lot about it today. And indeed, you can learn how to do an effective family meeting. A couple of things we have to take care of before we do that. Let's see if we can get my screen to move forward now. There we go. So I am a retired nurse practitioner. I have no disclosures. There is no one who wants to give me money, although I will say that in retirement, I have a very robust friends and family pro bono practice, surprisingly robust. The pictures show I've been spending my retirement traveling. And for those of you who don't recognize where these places are, they're not in the US, and I'll gladly talk about them at the end with questions. We have a couple of objectives today that were required so that you can get your contact hours. We're going to talk about how to prep a meeting, how to conduct it, talk about the things that can make it go well or not, how to talk about really tough and difficult topics, and to examine ourselves and know what we bring to the table, good and bad. So just to be sure we're all on the same page, what exactly is a family conference? So family meetings between the patient, their family, and healthcare professionals have a lot of reasons. We share information, we talk about the goals of care, we talk about what the treatment plan will be, what the prognosis is, and we try to develop a plan of care together. Seems pretty obvious, but often we forget these steps in the meeting. Now, please know, it does take skill to lead a difficult conversation and a family meeting. And situation we have as providers with preparation. We practice, we learn, we read, we study. People who do this well are not just winging it. And if you go in and just winging it, probably you're going to find that your family meetings do not go reliably the way that you hope they will. It really does take skill. We're going to talk about that skill set. You need to know how to facilitate a group. And if you're an introvert, that may not be your top skill set. You need to have true empathy. You need to be really patient. And we're all super busy, so that is challenging. You need to really be able to counsel people and counsel in a group. You need to know what's going on in the medical setting exactly and to be able to speak to it intelligently. And you need to be able to provide some direction in how people make their decisions. These conferences happen wherever you work, anywhere the patient is, whether it's an acute care setting, in hospice, in a facility, in the home, or in your ambulatory clinic. It really is anywhere you are. And now it can be virtually done. And so it really is everywhere. Why do we do it again? We want to, at a pivotal point, provide important information to the patient and the patient's family. Sometimes communication has been confused or we're not sure who has told who what. And so clarification of that is really important. We want to really specify what the plan of care is going to be. We want everybody to be on the same page. And we really want to build trust between the patient, the family, and the medical team, and to provide support to them as they go through this often life-changing place in their lives. Now, I have a little bit of a business background and I have a bias about this because I do believe that we have a lot of different customers. And if we look at it as a customer-based provision, it gives us a better sense of how we need to be as the coordinator of this customer transaction. So the patient is obviously our customer. And the people who make referrals to us for these conversations are obviously our customers. But sometimes we forget the family is also part of that equation. The other caregivers are part of that equation and the other staff. You would be amazed at how much information the cleaning people can give to you about what's going on with your patient and the decision making. You would be amazed at how important it is to get all the other caregivers and staff on board because if they don't agree with what you've discovered, they're going to potentially undermine or sabotage all your hard work. So be sure you're aware of who is all in that arena for the patient you want to give a family meeting for. And what is your job? Well, you're the host. And I find that this aspect is often missed by providers. You are literally the host. The buck stops here. And you need to be sure that you are hosting a meeting that represents the meeting you want to have. Again, it doesn't just happen. You are also a provider of care to the patient. You're providing palliative care and you have that provider role. You're facilitating a conversation, and facilitating a conversation doesn't just happen, particularly if you're not a highly social person. You may end up being a mediator. And this role can be super important when there's conflict in the meeting, which often is the reason we're having a meeting in the first place. And you are a translator. This is a role I find people are often also forgetful about. Not everybody in the meeting, in fact, most people in the meeting probably do not speak medical. And if they do not speak medical, they are not understanding what you're saying. So you need to be able to take highly complex healthcare information from the record and from the providers around you and translate that into what it means for this patient and family and what conclusions can be drawn from that. So you need to be thinking about the goals of the conference. And often we're thinking about our own goals, what we're trying to get from it. And again, that inform, clarify, plan, same page, support, trust part, that's obvious. But those goals are probably not, I was going to say may not be, but actually are probably not the same for the patient, for the family, for the healthcare team, and for you personally. And if your referring providers are bringing you in to close the deal to get the DNR, then the goals all around you are probably for sure not the same. And you need to be aware of the goals for all those involved. So think for a minute, just step back for a minute. What do you know about your own decision making in a crisis? For each of your patients and families, this is most likely something they've really never gone through before, and it is a life-changing moment in a person's life, in a family's life, in relationships, and it's often a crisis needs to be done fairly quickly. There's that time pressure. How do you know about making decisions when you don't feel well, if you're sick? I know that when I'm not feeling well, and I'm actually a really healthy person, but if I'm not feeling well, I almost have brain fog. And I identify that in part because I read a lot. And when I am really not feeling well, I cannot concentrate on the written page on a book. I can maybe page through a magazine, but that's it, or scroll a reel. And so when people don't feel well, their attention span really may be reduced. Please know that when you enter the dynamic of the people in the room, the patient and the loved ones around them, there may be some pre-existing relationship stress. In a crisis, people may show up for whom there are huge conflicts and they really don't want to have any regrets. There may be disagreements that are long standing, and you may have the matriarch or patriarch of the family in the bed not feeling great. And so these conflicts and this future thing can really be a subtext for that meeting. Be ready for that subtext. Please know you are bringing bias to the conference, implicit and explicit. And you have to think about how you are going to manage that. So we're going to take a case of a tall female who's 5'10" in her socks, 6 feet in her shoes. If she wears heels, 6'2" easy for eye level, who, if she's dressed in a black suit and heels, is pretty intimidating because she is an RBF. She is a resting cranky face. And so that bias that I bring, not only internally, but externally, has an effect on a meeting because it could be very intimidating. And so you need to think about that external bias even for how it will be perceived. And consequently, for someone like me, I have to consciously think about bringing a smile to my face. I wear softer colors, never jackets, bulkier jewelry that's natural stone, so it's usually curious or interesting, something that softens that cranky, stern exterior. I'm white. I have a lot of privilege. I'm affluent in the community. I am healthy, and I've been healthy my whole life. And so I have this viewpoint taking for granted that health. I am self-determining, and I care about self-determination. And I have been able to self-determine my entire life, which is actually unusual somewhat for a woman still of my age. I am well supported socially. I have family and friends around me, and I expect people to tell me the truth. And all of those things affect what I hear in the conference. And so you need to be able to think about your own self and what you bring to the conference. Please know, even if fashion is not your important thing, that bed hair never goes over well. That there are perceived standards of professional attire, and it's a whole different conversation. But how you look makes a difference for how you will be received, because what you are bringing then to the conference is potentially that you don't care about them, that you don't respect them, or that you, if your exterior is slobby, maybe your interior is slobby as well. So please consider there are a lot of factors that you bring into a meeting that will affect how it goes. I'm not trying to put down being tired and coming out of the sleep room and all the things that we go through. I mean, many conferences happening after crises in the ICU. I get it. I worked in the intensive care unit for the better part of 30 years. I get it. But how you present yourself still makes a difference in the confidence that will be felt and experienced by the patient and the family. This is probably the most important slide of the lecture, actually. I can teach you the how-tos, but this part's on you. You need to care about the people that you're working with, the patient, the people who are making referrals to you, even if they are jerks. And even if they've said jerky things to you, you need to care about the family, even if they're difficult and really different from you or intoxicated. You need to care about the caregivers and the staff, the caregivers that are non-family around the patient. And if you don't care, if this is just a case to you and a number and another step to get through, I promise they will all know. That brings the question, can those empathic, those caring skills be learned? We all know that empathy works so much better if it's not an act. Teddy Roosevelt once said, nobody cares how much you know until they know how much you care. And that probably actually is the theme of this talk. You need to be able to share with people how much you care. And underneath that, you need to actually care about it. And if you're not caring about the person and about the situation, you may not be the person to lead the conference. Please evaluate yourself in those moments before a conference is going to happen and determine if you are the person who should be leading it today. There is a significant study about this, and we know that as little as 30 to 60 seconds of gentle emotional support is associated with reduced anxiety among patients making difficult medical decisions. Now, it's absolutely common sense. I get that. But there's actually good research that demonstrates this to be very true. And so, those questions that you ask at the beginning, so tell me about the patient. What are the things you like to do when you're feeling better? Have you read any good books lately? Look for cues in the room around you to see if you can take a moment to be a person and make some connection and give some emotional support. So there's a lot of evidence on effective family meetings. The original research, which is partly when I got interested in it, was in business, make the sale, and in psych, in anthropology culturally, and even in the educational literature about how children and adults best learn. It's now well established. There's so much research on family meeting formats, particularly it started for ICU patients. My thesis actually about 100 years ago was actually on family meetings in ICU, and I can say with some gentle pride that I helped to move the needle on those ICU visiting hours, which were for 5 minutes every 4 hours at the time and are now wide open as we know them today. I'm not saying I moved the needle. I'm saying I inched the needle and nudged it, but that the origin of my interest in this topic goes back right to the very beginning of my career. There's a lot of research about difficult conversations with oncology patients, about surgical consent in the operating room, and just tons more now. The NIH has a whole section on it. Our palliative care resources do a ton of work on this. There is so much that can be helpful to you on this topic. We also know that as focused as we are on science and double-blind studies, it's really, really impossible on human interaction, especially in a crisis. I actually encourage you to consider, which is a counterpoint to all of our emphasis on double-blind studies, is to consider exploring a little bit of the phenomenological research on this topic. As Brene Brown once said, maybe stories are data with a soul. And so there is something to gain from that storytelling as well on this topic. So on your board exams, there will be mention of the spikes model. I'm going to put it there so you can pull it out when you look back at the slides. It brings up the obvious things I've been talking about. You're going to be looking at the setting of this conference, what the patient and family are thinking and what they know. You're going to ask for an invitation to tell them about what's going on in the situation. You're going to share that information. You're going to address emotions with empathy. You're going to strategize and summarize. I'm going to move past this slide quickly because I'm going to talk about each of those items individually. In a meeting, before you start the meeting, be sure you know who gets to make the decisions in your meeting. There's a whole lecture of this, and it's actually next week. And I'll talk about it in great detail so that you can have some comfort about this. I find that we often slide on this and make assumptions. We've all seen someone rush into a bedside, really give detailed information to the two people who are visiting the patient, and rush out again. And the nurse at the bedside then has to address the questions that the pastor or the vicar or the deacon and his wife had about what those decisions were that they just made for the patient. So please be sure you know who's there and who gets to make those decisions. You want to know about the patient and whether they have capacity. You want to know whether they have a patient advocate or a medical durable power of attorney. Or do they have a guardian? You want to know if you're working with family consensus, whether providers will be participating in detail in the meeting. So we'll talk about this next week. So the setting matters. Review the available patient information. Be sure you're prepared. You may need a meeting before the meeting where you sit down with the other providers, the referring customers, the staff, or the bedside caregivers, and ask what they're really concerned about and what everybody hopes gets accomplished at the meeting. Be sure you know where you are meeting. And I gotta tell you, if you bring a family into a staff lounge and there are dirty half-used coffee cups all over and a mess of papers on the table, it does not make a good first impression. Be sure there are chairs for everyone. Now, you never know what's going to happen until you get there. I know that's true. Please also know that you may end up having two meetings, one that I would call the warning shot, and the other one that is the decision meeting itself. And what I mean by this is you may have a meeting area where you bring people, you have that conversation about the patient's wishes, about what's going on in the meeting, the information sharing, and they may need a minute to talk. And by a minute, I mean a couple of hours or maybe an overnight. And so be prepared that when you are giving a chunk of difficult information, people may need to process that a little bit. And so it's absolutely okay to go in with a plan that is, we'll talk to them. And if they seem to have questions, that we'll just say, you know what? It's 10 a.m. now. Would it be all right if we meet here again since everybody's here today at 3 p.m. and see what your questions are and where we go from here? And that time in between can be very important for having a meeting go well and for the family to have time to really figure out what's going on and what their decision is. Now, there are, since the pandemic, some very special considerations for meetings when you can't be all together in the same room. And I think we've always had situations where we dialed in a family member who was in a faraway state, and that is very appropriate. Wonderfully now, most of us are used to virtual meeting platforms, and most organizations have a virtual meeting platform that they use so that you can literally FaceTime someone in a good way. You can do that for consent, but you still need your consents if you're doing any kind of telehealth. You do have to maintain all the confidentiality, HIPAA kinds of concerns. Your setting and impression still works. And I'm going to tell you, my setting behind me is lousy. I practiced when it was daylight yesterday. I have a beautiful fall vista behind me, but had to draw my curtains because the lights glared on it. So beware of details. So your setting matters. And then you may need to help a patient or family to participate on a virtual platform if they're not familiar with it. And so be sure you understand it or have someone who can assist you, which is even better, at making that virtual platform work. So we start a meeting. You want to make sure the patient is comfortable, whether they're present or not. So I make a habit and made a habit of buzzing in to see the patient, maybe an hour before the meeting, just a quick stop, or making sure one of my colleagues could go and stop in the patient to make sure the patient is comfortable. I promise you, nothing derails a meeting faster than the patient being miserable when the meeting's supposed to start. I promise you. And then you have your time lag for any of your interventions to work. So if you show up an hour before a meeting and the patient is nauseated or in deep pain, be sure you address those topics. And sometimes you can even call that in to be sure that they're comfortable either to participate or so that the family can comfortably leave the bedside. I strongly recommend that you sit down. I do not recommend that you be in the alpha position where the patient and the family are at a lower position and you're standing. It does not lead to good conversation. Be sure that you are sitting down with them. Take a moment to verify that everybody who needs to be there is present. If you jump into the meeting and they're waiting for the most important person to get in there because the parking structure was crowded, they will not be paying attention. Take the time to introduce everyone in the room to be sure you know who is sitting there. Sometimes there are a few very vocal people who will be present and they are not part of the decision-making circle. It's okay if they all want that person to be present. We'll talk more about how to determine that next week. But if the person asking all the questions is really not a member of the family, you need to be aware of that. Talk about what you're bringing to the meeting, what the purpose of the meeting is, and most of all, again, start that meeting bringing the patient present if they're not present themselves. Tell me about the patient. Then the real meat of the meeting begins when you're finding out about the perceptions of all present. And ask them to tell you what they know about the patient's condition so far. A few phrases you can use. So, what have your providers told you about your condition? How do you think things are going? Tell me about the past 6 months. What kinds of changes have you noted? Sometimes this meeting and the information that you have seems so abrupt to the patient and the family until they start to talk about the decline that they've been seeing over some time. And they'll say important things to you, like, yeah, she's been eating like a bird for the past year. So that the questions that they have and that you have about how to proceed nutritionally aren't a surprise. It's not abrupt. Or, yeah, he couldn't get out of the chair the last 3 months without help. And, or yeah, I knew he should be using a walker or something, but he just refused. There can be really important things that help bring the family to the same place you are when you ask about those changes. It is often also super, super important for you to figure out how much does the patient want to know. And we'll talk in a minute. How much the patient wants to know and how much the family wants the patient to know may not be the same thing. And you need to know that. And it's not hard to find out. You just need to ask. But the asking is sometimes the thing we forget to do. So your next step is to ask them if you can provide information and get them up to date. Be succinct in your summary of the condition. Don't use medical jargon, or if you are needing to use diagnostic terms or jargon, be sure you define what that means. I will never forget an episode when my mom was in the ER. She had a UTI sepsis, and my sister was with her, and I happened to be on a little getaway up north, wine tasting actually, and my sister was spelling things to me in the ER, Levophed. So at that point, I knew I needed to get in the car, actually, my husband, and get home. But please be sure that if the family has to spell out things, that they need a little bit of more information to go along with that. If you're giving medical jargon, also take the time to spell those words. And if there aren't any pens or paper around, that in your meeting prep can be something really good to provide. And in your meeting prep, tissues is always a really good idea. When you're giving information, I recommend that you talk about and contrast the burden of suffering, and the benefit of treatment. I am not a fan of pros and cons because it rarely is a pro and con situation. It's really a fork in the road where the benefits and the burdens are just different. And we need to know what the patient wants. You want to also let them know what the team is doing to help the patient be comfortable. So I talked earlier about before the meeting, making sure the patient's not having uncomfortable symptoms, but also know that if we have done a great job and the patient looks fabulously comfortable, the family will have a hard time understanding what the suffering is. And I promise you, when you've got double pressors running at an ICU bedside, the family does not know that. They do not know how vulnerable and tippy the patient is. So you're going to have to talk about what you're doing to help keep the patient comfortable, to help them balance benefit and burden, and let them know that there's a time limit on some of the therapies, that your body can only handle double pressors when you're 88 years old for just so long. And so be sure they understand those situations. You can also talk about those bridging therapies, things that you do that may get them back to health, but may not work, but are not sustainable, that can't last forever. And there are tons of things that we do for patients that are okay for a while, but don't work. My own dad had prostate cancer. He's gone now, but when he was on immunotherapy, after about 2.5 years, of course, he started to GI leak and bleed a little bit, and he would need blood transfusions. And of course, his bone marrow was suppressed. And so blood transfusions worked every other week for about 3 months, and then every week. And we got to about 4 months, and then he was asking, well, why can't I have them twice a week? And so we had to have that really hard conversation that we're at that fork in the road where your immunotherapy may not be helping, but it's certainly hurting. That benefit is unclear and the burden is here. And this bridging therapy of your blood transfusions, it's time limited and we're reaching that end. And those conversations will be real for you and for your patients. And like I said, I just want to emphasize, listen, don't ramble on. Listen, don't ramble on. It's really important because what they say will make a difference. To summarize, say something that really is a bottom line statement. Some examples. It's no longer medically clear which option is going to benefit, or the medical team has a huge concern for suffering here, or the patient seems to be getting worse despite everything we're doing, or we do not expect this to improve. Time is likely very short. Then allow silence. Just stop for a moment to wait for the family and patient to respond. 5 to 10 seconds, and I mean silence, this means you. And so I'm going to take 10 seconds here of silence in the room because it's longer than you think. And when I was new to this action, I really had to sit on my hands and count it out. And so here comes 10 seconds starting now. All right. Now, just so you know, most people, me included, can hardly stand a situation after 5 seconds when no one is talking. So that's good to know about yourself. And in addition, that will be true about the patients and family present. But that time gives even the most quiet person the time in the conversation to take the space in the conversation and give a response. If there aren't any questions or responses, it's okay for you to go around the room, around the circle around the table, just to say, so James, what do you think? Carolyn, what do you think? It is really helpful for that to happen. Take notes on what they state because you're going to want to document that later. If you have a colleague with you, you can designate one of you to be the clerical person, the secretary of the meeting, and take that down. It's very helpful for you to get a sense of where they are and to kind of call that roll call around it. So there are a couple of situations that can be challenging in family meetings and that can really stump people, especially who are new to coordinating family meetings. So sometimes the families will say, don't tell my mom, she has cancer. And we all have a huge ethical value, which is the patient deserves to know what's going on in their situation. And so if that happens, just to ask them, so help me understand why you don't want me to tell her. Is there something you're afraid I'll say? Sometimes they've had some interesting previous experiences where someone came in and said things that were not understood correctly, and it was the way they said them, maybe medical jargon or catastrophic phrasing. And so knowing what their previous experiences are can really make a difference. And there may be, in this situation, a personal or cultural or religious context, and just inquire till you get the sense of that. If it doesn't still make sense, take some time to listen. Let them know you want to honor them, but that you also have an obligation because that information is the patient's right to have. And so say, can we talk together about this with your family member so that we can have this go well? And if they're really, really strong in their sense about that, take the time to work that through. One of my other favorites is, but he's a fighter, as though fighting to stay alive was different than fighting to stay comfortable, and that they aren't the same. Some phrases that are helpful. Most people are fighting to live as long as possible with the best quality of life they can. Fighting their disease has been our strategy so far to get to that goal, but that strategy is no longer working. We need to consider a different strategy that looks at comfort and quality of life and fight just as hard or harder for that. And this can be extremely comforting for a family. Be aware of conflict. Sometimes there's some information gaps, misunderstandings. Sometimes there's a hearing deficit or a language deficit or cultural issues in understanding. Be sure that everybody's on that same page. There are often treatment goal differences. There can be huge emotions about if there's unresolved conflict between, say, children and parents, the children may really hold out much longer before making end-of-life decisions in the hope that they'll be able to resolve that conflict and not have regrets about it. There are amazing family dynamics, and culturally and racially, a large number of our patients who have mistrust of the medical team with good reason, with good reason. So beware of that conflict and listen. Just listen and see what they're saying. If the family has to make a decision, some phrases that can help are, there are some things that would be really good for you all to talk about together. Beware of the family systems and boundaries. Be sure you dial in people who can't be there and spell medical terms, especially because a lot of people are going to have that family friend who's a nurse or a doctor or a PA or an NP and want to have input into that decision. Plus, then our favorite Dr. Google. You may be called upon to assist with substituted judgment. Substituted judgment, number one, brings the patient's voice into the process. It frames decisions around the patient's goals, the plans for specific treatments. And what you can say is something like, given what you've told me about your mother and what we know about her medical condition, I would recommend the following. At some place in all of our education, we get that point where we're not supposed to give that advice. And that really is not either accurate or based on any of our healthcare education backgrounds. We are permitted in every situation, including end of life, to give a recommendation about the best plan of care, knowing our bias in the situation. Just beware of your bias when you give your recommendation. Many patients are going to be aware of that. My husband has a pickleball injury, no surprise about that. And he was referred for this injury to an orthopedic surgeon. So he was really panicky that he would get surgery from an orthopedic surgeon and was very pleased when he got physical therapy. And so I'm letting you know that sometimes our biases can interfere with an honest recommendation about the medical condition. But as palliative care providers in particular, bringing together all of the input from all of the specialties, we really can say given what you've told me about the patient and what we know about what's going on with them, here are the things I would recommend. Please, please, please talk about the true benefits and the burdens. So sometimes a feeding tube is the question, and if you sincerely believe or know that a feeding tube would not be a good idea in the situation, you can say things like, feeding tubes are not recommended for older adults with advanced dementia, if that's the situation. You can offer careful hand feeding for persons with dementia. This is a good example about that. And let them know that there can be known risk that can be accepted. But there are risks with tube feedings that for some reason, most people in the public don't understand. There's this strong belief that if you put that formula in that body, that it's going to bring nutrition. And they do not understand the side effects and complications that come with that process. So you really need to talk with them about the burdens of feeding tube therapy if there are burdens in the situation. Be sure to let them know about the diarrhea, about the skin breakdown, about the agitation, about the need for restraints in that situation, about the worsening pressure ulcers if they have skin breakdown. Please, please be straight about the burdens. And about the feeding tube is not the only situation where we maybe don't give a great picture about the burdens of therapy. So just beware of benefits and burdens. I am going to give you just some phrasing about pleasure feeding as well, because often we don't really know how to share that eating can be really important to people and to families. You know, celebrations around food can be really important. And you can say to them, given the age and vulnerability and decline, we have a risk of aspiration here, but it's acceptable. We can accept that known risk in exchange for allowing the patient to continue to have their day-to-day activities and participate in things that are meaningful for them. And I'm going to add a few other things about known risk. Many of you know I care for my mom, and she's 90, almost 91 now, and still kicking people's butt at euchre. And we love her to pieces, and we accept some known risks for her. We have figured out very clearly that a systolic blood pressure of under 130 is not great for her brain perfusion. And so there are known risks for what you maintain for systolic blood pressure. Ditto for blood sugar. She's petrified of having to give herself insulin or have someone give her insulin and to diet control that. And we tolerate a little bit higher blood sugar because she feels better. So be aware that you can talk to people about known risk. Every time we encounter a new provider, do we have to talk about the known risk for her systolic blood pressure? Yes, I live in fear and have sheets written for my siblings so that if my mom ever has to go to the ER while I'm on travel, that someone doesn't try to fix her blood pressure along the way. So just be aware there could be a lot of stuff going on there with known risk, and it's okay to accept known risk. Let's talk a little bit about vent withdrawal. Please, please frame those decisions around the patient's goals. I am not a fan of compassionate withdrawal or stop aggressive care because we are going to continue aggressive care and we're not compassionately taking something away because it's to the patient and family appearing like it's keeping them alive. But talk about what life support looks like and give a short-term and long-term picture for options. I appreciate it when we talk about that we have a therapy that's a bridging therapy that's not sustainable long term without a huge amount of suffering. And patients and families generally are not interested in suffering, but no one has made clear the picture of what that suffering might look like. Let's talk a little bit about code status discussions and an introductory phrase. Have you ever talked together about how the patient feels about life support? Talk about full code, intubation, mechanical ventilation, CPR, and defib. I know there's a lot more. I know there's pressors and non-invasive ventilation, but these are the big four that are going to make a huge difference in the conversation. And if you talk about a lot more than that, especially in your initial conversation about code, their eyes are going to glaze over and they aren't going to be able to absorb anymore. Please talk about it in a way and pay attention to how it's going for people. Partial code, a lot of us are not a fan about it because we know that care of the breathing and care of the heart comes together, that you have moments between caring for the heart with CPR and defibrillation and caring for the breathing with intubation and mechanical ventilation. But they can be highly symbolic to patients and families. And so please beware that you can honor those patients' wishes in that situation, even when it's somewhat nonsensical, because you can gently give that advice and bring them along with that. Be sure you document whatever you decide about your orders. Be sure you document what they're saying so that that can be part of your decision making if a crisis occurs. It is really okay to say to families, there's something we're worried about, and I'd like to share that with you if that's okay. And to tell them, we would not be surprised if there was a sudden change in your mom's condition. We would not be surprised if her breathing suddenly stopped or if her heart suddenly stopped. It's also okay to say, I don't see anything that suggests that right now, but when it happens, it's usually sudden. Patients and families tend to think that decline is just a very gradual slope, and we know it's a slope with a cliff. And so it's okay to tell them that there will be we would not be surprised if there was a sudden change in condition, and we don't want them to be surprised either. I truly was transformed by an experience early in my career when I was at the bedside of an intubated patient, and the wife at the bedside said, "Did you, in the morning after their code, said to me when I arrived, did you know this might happen?" And the truth was, I knew it was possible, and no one, me included, had talked with her and with him about the process or what his wishes were. And she literally said to me, he would never have wanted this. But he coded, she wasn't there. The code status was full. He's in the ICU on mechanical ventilation and sedated, and they're devastated. At that point and with that experience, I vowed I would never not say this if I was thinking it or if we were thinking it. Now, an often troubling for some aspect is when people are hoping for a miracle, especially if it has deep religious belief behind it. And when people say that, and particularly if you don't share their religious belief, it is very appropriate to say that you also hope for unanticipated recovery, a miracle, or a scientifically unexplainable event. But it's also okay to say, but that is what it would take right now. Please, if you are seeking a miracle, do everything you can with your friends and family to seek out that miracle because that is what it's going to take right now. Um, if you're like me and I have a long career both in critical care and in palliative care, I have seen more scientifically unexplainable events that I really like to talk about with a lot of people. And I am religious, so that whole thing about miracles makes sense to me. And I live at the intersection of faith and science in a way that's comfortable for me. Your place is going to be different than mine. Be sure that you know how to be there for your patients if they are hoping for this miracle. And you can also say, sometimes things don't go as well as we hope. I want you to be ready for everything. Please do not say, I want you to be ready for the worst. Patients and families hate that. Don't tell them you want them to be ready for the worst. Tell them you want them to be ready for everything. And then you can say, if you get your miracle, let me celebrate with you. But I want to be ready. I want you to be ready, no matter what happens. Close up that meeting. And be sure you talk about the patient's goals, lots of phrases you can use. What are you hoping for now? What's important? Is there anything you need to accomplish? What do you see for your time that's left? What would the patient say? And restate what you understand the goals are. What I hear you saying is, and state your goals. Develop a plan based on those goals. It might be about future hospitalizations or ICU transfers or code status or blood products or invasive ventilation or advanced therapies or whether there's a second opinion, other treatment options they might bring into the conversation, and then recommend what the best disposition is to meet the goals. For example, hospice referral. Close the meeting. Restate the goals and the plan. See if they have any questions. Please take time to say, we will take care of your patient and family member, even if what you choose is not what we recommended. Many patients and families are worried that if they want to take a path that is counter to what you believe, that you won't care for them. Thank everybody who's present and gently leave the room, giving them the time they need to talk. Remember, in family meetings like this, there are a lot of pitfalls and challenges. Giving too much information is a real thing, and that one's on us. Oversimplifying the situation and missing some of the nuances and gray areas, often on us. But I will grant you that patients and families may ask you to, cut to the chase and say, what's the real question? Be careful if they have loaded vocabulary, things like you're starving them or you're going to kill, I can't kill them. Be ready for that and how to deal with it. Be ready for escalating emotions. Grief is real and it can be big. And be ready for feelings of guilt, which can come out loud. Pay attention, listen to see if there are some unrealistic expectations, and be sure you talk about that. Beware of cultural, language, and religious differences and any other aspects of implicit bias, which also is a solid lecture all by itself. Remember, if it didn't go well, it may not have been about you. Some patients and families are hard to connect with, and if you didn't get the outcomes you were hoping for, you'll probably get another chance. It's just the reality of it. Document, document, document. Report who was there, critically important, what you said, and what the goals and plan are. Take the time to debrief with the staff and with the caregivers and with your colleagues about what went well, what you would do differently next time, and address any emotional reactions. The part about not getting connected to your patients, it's garbage. And so you can have some real feelings about that. Or if it didn't go well, you can feel bad about that. And so be sure you take care of those feelings and take care of yourself as well. You're going to do the best you can with what's thrown at you. And then you may try again. One of my favorite philosophers, Mario Andretti. Got some references at the back of the slides. Anybody, any questions? I think I'm going to stop the share now.
Thanks, Barb. This is wonderful as always. As I mentioned at the outset that I always learn something new, and something that really caught my attention this time. And it could very well be that you've had this in previous lectures, and I didn't catch it. But you said the patient's story is data with a soul, and for some reason that really captured my attention today, because I thought about how often we see this collection of lab studies and X-rays, and we don't appreciate that. I was at a conference last week, and I was in a panel discussion. I was kind of facilitating this panel, and one of the things that I had commented was that if you put my medical history up on a slide, I look like a pathetic old man. And and I thought if that's all anybody sees, then they're kind of missing. They're missing a lot. And so that statement, the story is data with a soul, just really, I appreciate that. I wanted to make two real quick amplifications of two things you said, and then I'll let anybody else respond. Right at the beginning, you had talked about the importance of how you present yourself as a clinician and as a provider. And that obviously is really careful. You look in the mirror and make sure that is this the person I'd want leading my family conference. But the thing that struck me was that for many of these conferences, this is going to be one of many that we do. One of many we'll probably do this week or this month. For many of these patients and families, it's the only one that they may ever have that's of this level of importance. It may be the most important one if they have more than one. And so I just think just keeping in mind the gravity of this to them and a sort of routine for us. And I think that kind of goes along with how we present ourselves. There's a bit of humility that needs to be infused in how we approach this. The other thing that just kind of caught my attention, you had talked about your dad's transfusions, and we're often talking with our patients and families about time-limited therapies. And I think that we need to make very clear more than once on the front end and repeatedly that these therapies are time limited. Because just as you had commented, they get into the transfusion, I think this is going to be indefinite. They get on milrinone when they go home with their CHF. They think this is just going to be indefinite. And even things like when we do have patients on tube feeds and TPN and things of that sort, they may not appreciate that these are time limited. These are just bridges. They are, they're going to end at some particular point in time, and helping them understand that on the front end. And even to the point, here are the things that are going to trigger when we're going to stop the transfusions, just so you know. Anyway, I'll stop talking and let the fellows ask questions or chime in. And so,
if I could, again, Barb, I too, like John said, love your talks. They're so insightful, and I'm talking to the fellows and students in the room here now and on the call. Another thing that I want you to keep in mind is a lot of what was discussed here is kind of also being discussed under quote unquote perfect circumstances. Consider the concepts of unlimited time, right? For the patient's family, for ourselves, right? Unlimited resources. It's great to have a room that's set up with tissues and all that. I've literally done this in hallways, not by choice, right? Sometimes out of circumstances. But what Barb said at the beginning about if we don't go in with a game plan, if we don't practice, if we don't think of our own objectives and how to develop these skills, this is a skill set that can be developed if we give it conscious attention. And so sometimes that perfect circumstance is just in your mind. Sometimes it's doing the replay. Those of us who have done this for a while and feel comfortable doing it are more comfortable today because we've survived the incredibly, I'm trying to think of an adjective that doesn't include a swear word. And then having good people like Barb and the people here to learn from. Okay, so if this seems at times challenging or daunting, that makes you normal. Our ask is that we stand in that with confidence to wherever we're at, right? Where it's growth mindset, progress over perfection. Then hopefully teach our colleagues as well. Sorry, go ahead, Barb.
No, it's all right. And I would add to that if you have an imperfect circumstance, when you know what would make it better, you can also recognize, okay, in this situation, we have added stress because the locale is less than ideal. So you can pay attention and listen to that and recognize that it may influence the outcome of the meeting and how it's experienced. You may not be able to accommodate for it in the moment, but you can be aware and do what you can do. It's that awareness that counts.
And then validating that too, right, Barb? I mean, sometimes an imperfect circumstance can actually, again, with practice, be turned to an advantage. I had a patient, I remember the room was freezing, and just simply being able to go get that person a blanket, right? Just that little, I mean, say a little act, but to her, boy, it made her feel physically warm. And now we had a connection. We've built trust. We're moving forward.
And it's absolutely okay to say, I wish I didn't have to talk with you here and now. To say, this is not where I'd like to talk with you. I wish I could take you away to a room that was quiet, but that's not available to us right now. And so I need you to know that although that would be my preference, I need to have this conversation with you, that you can acknowledge a less than ideal situation and what your wish would be. It personalizes your time with them and lets them know you recognize the situation. You can apologize if you have evidence of a hard day's work on your clothing, which happens. It's okay for you to say, I apologize that I did not have time to change before I came for our meeting, but this is so important that I wanted to get together with you before you needed to go. As John said, these meetings are often a sacred space for family in terms of the family dynamic. It is frequently, if not most of the time, about end-of-life decisions. And so that sacred space, regardless of if you have a religious viewpoint on that or not, that sacred space for end of life, giving that some respect, if it's an imperfect situation, makes all the difference.
Well, thanks again, Barb. Once again, you hit it out of the park. We'll look forward to next week and seeing you then.
Thanks all. Have a good day. Take care.